today, Rosen. I've known Ilene since her medical internship. She and I are both Penn lifers, and I followed her career forever and ever with much admiration, pushing into awe at times. And it's a real privilege for us to have her with us today. Ilene followed me after chief residency into pulmonary and critical care fellowship training, one of the early women to break into a specialty that was dominated by men far longer than most others. And really, from the very beginning, she started breaking the rules. Ilene, early on, carved out an interest in academic education, medical education research, with a primary focus on graduate medical education, and work that she performed as a chief resident was published in JAMA, prescription drug use and self-prescription among medical residents. Had a great deal of impact at that time, not only for revealing an awful lot of use of psychotropic drugs self-prescribed amongst households, but also for breaking into a place like JAMA with medical education, graduate medical education research. Ilene has carried forward that interest in medical education as an organizer and as a master teacher and as a scholar straight through to the present. And early along the way, she opened up a second area of interest in sleep medicine, earning herself board certification in sleep several years after she completed her pulmonary and critical care training. Naturally, her research fell at the interface between the new unproven field of medical education research and at that time a fairly young medical subspecialty of sleep medicine, as she focused continued work on the health of house officers, particularly those who experienced extraordinary sleep deprivation that was common during those times when people served every second or every third day on service. Work that she performed and others who followed behind her was absolutely instrumental in leading to work duty hour restrictions on house staff. The work that she did at this interface has opened many doors to her within medical education. She is assistant dean for graduate medical education at Penn and vice chair for education on a 500 faculty member department of medicine. Along the way, she also became active in extramurally and served as the president of the American Academy of Sleep Medicine in 2017, 2018. That's the premier academic organization for sleep medicine worldwide with 11,000 members. So I know Ilene as a friend and as a master clinician, as a go-to person for my problematic patients, but outside of Penn, she's known for innovative and highly influential leadership, both in medical education and in sleep medicine. So she's going to be talking today, giving us an introduction in sleep deprivation, and I'm sure everybody's eager to hear her speak.
Well, thanks, John. I really appreciate that. Let me share my screen. Let's see if that works. All right, can you guys all see the big slides now as opposed to just the presentation?
Yes.
Okay. All right, so John, thank you for that great introduction. We were reminiscing, Judy, John, and I over email, or maybe Judy and I were reminiscing about how I really got interested in critical care specifically. In fact, I applied in pulmonary because of how much I loved the ICU, because John was my attending when I was an intern. And I found that I really loved the pathophysiology, respiratory pathophysiology that was in intensive care. And at the time, you were able to do sleep kind of as part of pulmonary critical care, which made a lot of sense. And then not because I don't like to be sleep deprived or because I'm a night owl, just for many reasons. I had to pick one field or the other and be able to do a lot of the education in order to be able to do some of the educational administrative stuff I do. But I still feel very much a part of the my pulmonary roots, and having been here for so long, the pulmonary and critical care division, and along with the sleep division. So what I want to talk about today is I thought it would be good to give you a little bit of kind of the sleep 101 and like orient all of us as to just the basic biology of sleep. I'll make it brief, and it probably will come back to most of you who have heard it before. And then I will give you some of I wanted to give you a little bit of the research specifically in healthcare workers. I won't dwell on it too much unless you have questions, but I've highlighted some of the things in here that you'll see. And then I have a lot at the end about managing sleep deprivation, because I think what you'll see sort of at the end of the day is that with our current environment of both training and working, sleep deprivation and shortchanging our sleep is somewhat of a part of our everyday life, and just knowing how to manage it is important. And then really on top of a major pandemic, many of us are in the house. Certainly our patients are, but many of us are in the house a fair amount when we're not working and schedules are off, and then all the social unrest, and even with a contentious election that occurred, there's kind of some new disorders out that I'll try to mention if we have time. So with that, I'll go ahead and get started. So here's your sleep 101. So there are some basic determinants of alertness and performance. Essentially, you may remember from your psychology class, or even in medical school, if you were taught it, that there's 4 stages of sleep. They're simply named stage 1, stage 2, stage 3 is also called delta or slow wave sleep. And then there's rapid eye movement sleep. And when you fall asleep, you start in stage 1 and slowly progress through the other stages. And then about 90 or 120 minutes later, most of us will have an arousal of some sort. We typically don't remember it. And then we go ahead and do that cycle again. And a good night of sleep typically involves 4 to 6 of those cycles that I just mentioned. And so the nightly sleep duration is important. I know everyone's kind of on mute, but anyone have any idea how much sleep we're supposed to get a night? What's the recommended amount of sleep? You want to unmute yourself?
I got 4 last night.
8.
8. Yeah, so the number is somewhere between 7 and 9. 8 is kind of the curve that most people see. We say at least 7 or 7 and up is the right amount. And I'm going to show you some data about what happens when we shortchange our sleep, not only if you miss one night of sleep, but in particular when you start doing chronic sleep restriction multiple nights in a row. In addition, the biological time of day, your personal circadian phase, and how it interacts with the biological time of day matters. I'll show you a picture of this in a second. And then on any given day, the number of hours you've been awake also influences how we feel. So I'm glad to be doing this talk at noon as opposed to 3 or 4 in the afternoon, because not only would siesta be the case, but if the longer you've been awake, the more the brain is telling you to go back to sleep, particularly if you're chronically sleep deprived. And then the last thing that's really important, if anyone's on the call who takes overnight call or gets awakened in the middle of the night, is sleep inertia. And that's the concept that the brain, as it if it is awakened out of certain stages of sleep, specifically stage 3 or that delta sleep, you can have this feeling of being hungover and maybe not even remembering that you woke up and did something and then went back to sleep. So it is complex, and I think this slide here is something I borrowed from David Ginges, or was given by David Ginges from the psychiatry department many years ago. And it just shows that this is that homeostatic drive for sleep. That's what we call that pressure that builds up in the brain and tries to get you to fall and starts to build up to the point where by 16 hours of wakefulness, there's really a lot of pressure to go back to sleep. We believe this is adenosine mediated and is sort of cluing the sleep switch to turn on. And then this is counterbalanced by the circadian drive for wakefulness, which is actually low when you first get up in the morning and then increases. Maybe we're about here, all of us are kind of about here, depending on if you're a morning lark and you've been up since 4 or 5 o'clock, or if you're a night owl and went to bed later and slept a little later. And then this isn't drawn exactly to scale. By the way, can you all see my pointer that I'm showing here or no? Do you see my pointer or no?
Yes.
Yes, okay, good. And then right around here this isn't exactly drawn to scale, but there's a dip during siesta period. So this is why taking a nap in the afternoon is easier and why the Europeans have it right. It doesn't usually dip quite as low as it does overnight, but nonetheless it dips and then it peaks again, such that even if you're sleep deprived and you didn't have a chance to take a nap in the afternoon, almost 6, 7, or 8 o'clock becomes a forbidden time for sleep. And then it repeats itself. And then in terms of our performance and alertness, on top of the interactions of those two processes, there's how stressed are you? How anxious does someone feel at any one time? How motivated are they for the task they're supposed to do? And how much caffeine they've had, and how noisy it is, and what their workload looks like. And certainly if they've done any physical activity around the time that you're checking their performance and alertness. And then I think it's also important to realize that we've learned over the years that there is a differential vulnerability to sleep loss. This is felt to be genetic. And this study is from 2004, but I still think it really shows the point very well. So essentially what you can see here across the bottom is the number of hours of awake. And then on the y-axis is something called PVT lapses. That stands for Performance Vigilance Test Lapses. And the Performance Vigilance Test is kind of it's a little sort of electronic game type of model where basically a light flashes and then you have to press on it as a reaction, and it measures reaction time. It also measures when the light went on and someone didn't hit it. And someone who's pretty resistant to sleep deprivation would have a curve that looks like this, that across being 40 hours awake, they have very few lapses. They're able to see the light and respond. Again, a pretty mundane task. And then there's the type 3 group who do okay until they pass that 16 to 20 hour mark that I was mentioning to you of wakefulness. And they start to do pretty poorly and max out at about 32 hours. And then they do a little better. Anyone want to guess why they do better? What's happening out here? This is the circadian drive for wakefulness playing in, even if they didn't sleep. And then you'll have to trust me that there's a type 2 in the middle that it was taken out of the slide to be a little bit dramatic, but you'll have to trust me that it runs right through the middle here, right through in the center. And so there are 3 types where one is resistant, one is very vulnerable, and one of kind of somewhere in the middle. It appears that these are split in probably what is a bell-shaped curve, and more people are type 2s than anything else. But I think the point is we don't really know how to test these individuals. And I would bet that people who come into medicine are like the regular population. And so we may have some people who are pretty vulnerable working in our health systems. Here's another really interesting thing about this is that this is the self-rating of performance of these same 2 groups. And this is the number of hours awake. And this is how they think they're doing. And what you can see is that everyone kind of thinks, oh, I learned this task, I'm doing fine, it's so simple. And then maybe they say, oh, I'm feeling a little bit tired. And then again, they start to feel like they're doing okay. with the task, in part because of their circadian drive for wakefulness. But the main point here is that both groups, these curves are not different from each other. And so there is a clear difference in how people perform, and they don't really recognize it. And so this is the reason why you hear people say that being sleep deprived has the same properties, or can be as dangerous as being drunk, because it has that same it has that same effect, that you're impaired, but you don't really know it. And then I mentioned to you earlier about what was the nightly sleep duration. So everyone, the recommendation for humans is 7 to 9 hours of sleep a night. And there are phenomenon of people who are short sleepers and long sleepers. They're small percentages of the population. Certainly some of them may go into medicine, but I don't think all of them would do help professional careers. And so we're able to recommend just get at least 7 or know yourself. And if you need 8 or 9, do that. And then I think some people just over time say, oh, I can get by with 6.5 on a nightly basis. I can't pull all-nighters anymore, but I can do fine with 6 or 6.5. And these two studies, which are also about 17 years old, but are really the best ones that show this concept of what chronic sleep deprivation does. So we'll look at the top one. This is a 14-day period. And then they had individuals who were allowed 8 hours time in bed, 6 hours time in bed, and 4 hours time in bed. And this is their performance lapses on that PVT I was mentioning earlier. And so what you can see is that across a 2-week period, those who spent 8 hours time in bed, they stay pretty constant. They get a little worse towards the end. But look at this group, the group that sleeps 6 hours a night. By the time they cross into that second week, and by the end of it, they're having the same lapses of attention that's equivalent to someone who's been awake for 24 to 40 hours. So this was a recognition that chronic sleep deprivation can have the same effect over time as someone who just missed one night of sleep, and that you have to pay attention to both those things. And in 2003, this was a pretty new concept. All I have on the bottom, I won't describe it, is that this is the group at Penn. David Dinges' group was doing this at Penn in 2003, and they were collaborating with a group at Walter Reed. And so Penn did a 2-week study with the even numbers, and Walter Reed did a 1-week study with the odd numbers. And you can see that even if 5 hours time in bed at night, those performance lapses are already seen really clearly at a week. Okay, so when I try to talk to particularly house staff or medical students or even nursing students about this, they often say, this is a short period of my life, and we're scheduled. We don't have much control over our schedules, and when I leave the hospital, I want to do other things, and I'm trying to fit it all in while I can. And I really try to impress upon them, and maybe some of you have experience with this, professional behaviors that they develop now become their lifelong habits. And if you are someone who tends to shortchange your sleep early on, I think that often becomes the case. I know it's something that I, in particular, have struggled with and really have to pay attention with, because of how little we were taught to pay attention to this when I was training. And so what are the consequences? So what I try to tell them is that you may feel like it's fine now, but what are the consequences over a lifetime of having many periods of acute sleep deprivation without recovery, or chronic sleep deprivation? And that is, there is an increased risk of obesity. There is an increased risk of, I wouldn't say risk. People tend to be more cranky when they're sleep deprived. And there's actually, if you sleep deprive someone enough, they will test positive on a depression inventory. So it is really important to pay attention to it. Sleep deprivation is associated with insulin resistance, increased risk of stroke, or being killed in a motor vehicle accident, a fall asleep crash. And in recent years, there's been a lot of attention paid to alterations in neuroplasticity, not just from sleep disruptions with sleep apnea and hypoxia, but just in general, what role sleep deprivation plays in altered neuroplasticity. And you probably could have a whole talk on just that. So I wanted to show you, I wanted to show you some of the data that was out there. And this study is from 2008, and there was a recognition that the effects of fatigue and sleepiness on nursing performance and patient safeties, and that if nurses were working shifts that are longer than 12 hours and are working without getting sufficient sleep prior to a shift, there was an association with patient health risks, personal health risks, and also risk of car crashes when driving home. And then about 6 or so years later, there was a study that came out in the American Journal of Critical Care that looked at the impact of nursing work schedules on sleep. And not surprisingly, that the sleep time between consecutive work shifts is short. So many nurses, as you know, will work several days in a row and then have a few days off. But, and so no one is hitting that 7 or 8 hours that we were mentioning earlier, but at least on day shifts, they're trying to get close to 7 hours, but look at what's going on the night shifts. They're really shortchanging their sleep. And some of that has to do with, we're not nocturnal, and it is very hard to sleep during the day. And that's one of the, I can mention some of the skills at the end. Hopefully we'll have time. And then their sleep was higher between the days with no shifts, almost 9 hours, which is a good sign they were trying to make back some of the hours. And then every minute of one-way commuting time was associated with a reduction in sleep time by 0.84 minutes. So David Dinges and I actually, for those of you who know him, used to give a talk together to the medical students. And I live in New Jersey, and he lived not far from the medical school, and he would calculate how many hours more of sleep he was getting a night than I was because of my commute from New Jersey. Okay, and then what about in our physicians in training? So since about 2000 or 2001, John was mentioning, it was just as I was starting my career, and this started becoming something that people were talking about more nationally. It was recognized that the sleep deprivation may be contributing to errors, although it was difficult to quantify. And there was a feeling that novice learners are the most at risk, and in particular after 16 hours of wakefulness. And while there had been some attempt to reduce work hours about in 2007 or 2008, the really sort of one that had a lot of impact and got everyone's attention was in 2011. The Accreditation Council for Graduate Medical Education set a 16-hour limit on the number of consecutive hours that a first-year medical resident could work. It could be night shift or a midday shift, but that it had to be a limit of 16 hours. And as most of you know, this is dramatically different than anyone had trained before. And because of that, that led to a couple of randomized control trials looking at the effect on patient mortality relating to resident duty hours. That was actually led by a group. The iCompare was led by a group at Penn. But these were actually multi-center randomized control trials. The first trial was done in surgery, and they basically randomized programs across the country to the 16-hour rule, or a little bit more of a more traditional, where they could have a longer call schedule. But both groups had to stick to the 80-hour work week, so they did limit the work week to 80 hours. And in the surgical study, there was seemed to be no impact on patient outcomes. They did not track sleep hours. I have some other slides on this if you want to talk about this at the end, but that's sort of the bottom line of it. And then the iCompare study was actually led by Kevin Volpe and David Ash and Lisa Bellini and David Dinges and others. Again, another national multi-center randomized control trial. We were in the intervention group where we were allowed to extend more than 16 hours. That study showed no impact on patient safety. It used a Medicare database. And also, interestingly enough, not on sleep duration. There was a question about whether or not it influenced performance and alertness. But in both of these studies, the group that was in the longer hours, the one that had could take overnight call, felt that their personal time and their well-being was negatively impacted. And so I do think, and by the way, and so after that time, the ACGME changed its rules, which I'll show you in a second, but I think it's fair to just call out that these studies and these trials were opposed as unethical by Public Citizen and AMSA. That should say 2016 to 2018. There was a lot of flurry about whether all of this was ethical and valid. They said there was no informed consent. There was no tracking of residents' outcomes such as motor vehicle crashes or depression or even of needle sticks. And by the way, there's a large body of data from the late 90s and early 2000s that are small one-offs, if you will. They're not randomized control trials, but do suggest that all of these are increased in residents and related to sleepiness. Patients were not informed of the assignments of interns, and the comment was that they prefer well-rested providers. They did not measure intern-specific health outcomes. Again, most of the data was collected over a year. And then they also questioned the results as others on the team were supervising the interns were working the 28 hours. So if the interns were only working 16, there was still a lot of people on the team who were sleep deprived. And it may have been that these results speak mostly to the layering that we have in the hospital, as opposed to being able to really measure any one person's fatigue contribution. So what are the current ACGME rules now? So clinical and educational work hours, many of you know this, must be limited to no more than 80 hours a week when averaged over a 4-week period. This includes all in-house call and all educational activities. So clinical work done from home, that was new. This is in the era of the electronic medical record and going home and having pajama time with their charts, and all moonlighting. And time spent on patient care activities by residents on at-home call, whether they have to come into the hospital or not, must count towards the 80-hour weekly limit. So if someone in their chief year is taking a lot of, or a fellow is taking a lot of calls from home, as you know, they have to count in the time and the amount of disruptions time they're spending on the phone and looking at the computer in their work hours. Studying and research done from home doesn't count. But this was the attempt to try to limit based on and balance the biology with some of the data. So how do we recognize the warning signs of sleepiness in ourselves and others? I just told you that it's oftentimes you don't realize what your response is to sleep deprivation. So I try to share this when I'm teaching residents and fellows and medical students. So if you're falling asleep in conferences or on rounds, that's definitely a sign of sleep deprivation. I always like to, people will say, oh, it's the boring speaker. So what I like to say is if you're well rested and you are listening to a bad speaker and you're bored, you're annoyed and distracted and maybe doing something else. But if you're falling asleep, that's really a sign that your brain needs more sleep. And when you're sedentary and checked out, you're starting to fall asleep. I mentioned the crankiness on that other slide. So feeling irritable with staff, colleagues, families, and friends. Can't complete tasks on time, difficulty focusing. I will tell you, I was one of those interns and fellows that used to like to make a lot of boxes on a piece of paper and walk around and fill in the boxes. And that as much as appealed to my organizational skills, I think it was a good way for me not to forget the most important things I had to do. And that's probably because of sleep deprivation. And then this idea of apathy and anhedonia, as I mentioned earlier, just being sleep deprived really can change someone's affect and can change their mood greatly. And then what I have been really happy to see, the one nice thing about the ACGME trying to regulate this a little bit is even if we might not all agree on how they went about it or what the current rules are, is that the culture has changed. I do think that we talk about this more, that we feel more comfortable saying, hey, you look sleepy. And so, because if we don't recognize it, we're not going to do anything about it. But I do think people are talking about this a lot more than they might have a decade ago. I don't have to tell this group about the impact of a 24/7 society, right? We're all overscheduled. People eat late, they work late, they watch Netflix. When I was the president of the American Academy of Sleep Medicine, I'm completely blanking on his name now, but the head of Netflix made some public comment that their only competitor was sleep. And so the Academy got really tried to push back on that and that messaging. Everyone, or many people, are subjected to chronic partial sleep deprivation, and they accumulate this sleep debt. And then many people, particularly in our profession, obviously have scheduled periods of acute sleep deprivation, either because they pull an all-nighter or because they're scheduled to work. There's gyms open 24 hours. There's a lot of 24-hour access now. And then obviously people can have sleep disruption from any number of reasons. And by the way, I didn't mention if the sleep quality isn't good because there's a sleep disorder. Certainly that's another issue. And then to really focus it in on healthcare professionals, again, I'm sure all of you could have made this slide without me. So we have insufficient sleep. We have on-call sleep loss and inadequate times for recovery sleep. When we do sleep, we have fragmented because of phone calls or texting or being contacted by the hospital, or if you're in the hospital, being awakened. Then there's the circadian rhythm disruption. So rotating shifts can be a problem, particularly if they're not done in the right way. And working nights, we're not nocturnal. It's really hard to adjust to night shifts. And then certainly we see primary sleep disorders come up at all ages, including in the medical school and beyond, where we have plenty of people who come to our practice and are trying to balance their professional life in the setting of a sleep disorder. And then there's this issue about what do residents do when they're not at work? So in 1999, some research demonstrated that moving from a first year to a second year, they gained an extra hour of non-work time per day, except that only 13 minutes of it was used for sleep. And then in 2012, a study by Baldwin showed that PGY2s were doing 49 to 50 hours per week of work. And in their off time, they were using the internet, watching television, and doing household tasks. Again, doing their life, as I said earlier, but they were still only getting 42 to 45 hours of sleep per week. Again, that's just barely about the 6 or 7 hours, not quite 7 hours, about 6.5 a night if you do the math. And what else do we know about the impact of sleep deprivation on resident physicians? So a couple of studies that was done in collaboration with Judy Shea and Lisa Bellini and myself was that we started looking at what was the effect of chronic sleep deprivation and how does it affect people over the course of internship? And in 2006, we tracked our interns over the course of the year with multiple batteries and also batteries of tests, including the burnout inventory and some depression inventories. And we had them fill out sleep diaries, although there are some challenges with that. But on that single study of 1 year, there was as people became chronically sleep deprived, they reported becoming more burnout and more depressed. And then as part of the iCompare study, Judy Shea led us in a study that looked at a 5-hour protected sleep time during an extended shift. So when we allowed the interns to take a nap, that it didn't have much effect in measures of depression, burnout, or empathy. There were some measures that were improved, but again, the ones that we were expecting and hypothesized did not. What's really interesting is that although they got a 5-hour protected sleep period, meaning they gave their pager or their phone over, they were only sleeping 40 minutes more, which means they were using it to finish the quiet time to finish their notes and get their work done and prep for the next day. And the other thing is this was only monitored for 4 weeks of one rotation. This wasn't across all the rotations for the whole year. And what about the impact of sleep deprivation on practicing physicians? So the American Academy of Sleep Medicine has called for the evaluation of the roles of sleep disruption, sleep deprivation, and circadian misalignment in physician well-being and mood, that should say. And in fact, I don't know if Indira Gurubhagavatula is on, but she was one of the people who spearheaded this position statement and reviewed the data, because there has been such a huge increase in burnout and in practicing physicians, and wondering how that relates to how much more many of us are working, given how really 24/7 medicine has become. And then also at Penn, we looked at what happened when we provided a nocturnist in the ICU, and how that, meaning that the attending actually, who normally took call for 2 weeks straight through and was in on the day and taking calls and home at night, would have coverage by a nocturnist overnight so that they could get some sleep. And that was associated with anywhere from 18 to 42 minutes more of sleep per night. And in fact, really interesting is that the fellows on the service, who are also allowed to, are normally awakened, slept more than the fully licensed providers. Which is a little different than some other studies we've seen. And then, but there were no difference in patient outcomes by having the nocturnist or not, and well-being measures in the group that had the nocturnist and were able to sleep actually improved. So I like to think about sleep deprivation in our profession, or in any healthcare provider, as kind of a two-pronged approach. There's an individual level approach, and then there's a systemic approach. And so it's really important on the individual level for us all to become aware of our neurobehavioral vulnerability to sleep loss and act accordingly. Again, I showed you that slide that it's hard to tell, but we all have people around us, and maybe we can think of some markers about how we might not be at our best, and at what hours that is. And then if we do get sleep deprived, we really need to ensure recovery sleep periods are sufficient. I'll try to show you something about that in a minute. We got to optimize our sleep environment. Maybe if we have control over it now, try to live close to work. And if there's a chance you're suffering from a sleep disorder, certainly seek treatment. And then about the system level, I think that it's really important for everyone in the system to understand the effects of sleep loss on performance and mitigating these with countermeasures, which I'll show you in a minute, and then also seeing how those countermeasures can be facilitated by the workplace. And the first thing is really simple: attention to scheduling, allowing sufficient time for recovery. There should be day to night transitions. So day shift, then evening shift, then night shifts, and then kind of back again to day, as opposed to going the other way, or sometimes doing days, sometimes doing nights, then back to evenings. Really understanding the science and the rest that's needed in between some of those shifts. And then we need to maximize opportunities for sleep when at work. I know the hospital is 24/7, and I know we already are sort of pared down at night, but perhaps we need to think about how to maximize our circadian prime time, perhaps maybe during the day. Maybe some of the staff that's going to be overnight could take a nap, or at least allowing for some nap time in the early morning hours, and giving that message as opposed to some of the work that has to get done. And then I have been working on this for a number of years, and I'm still not there yet, but I really think that we should think about maybe not having call rooms per se, but think about having nap pods. This is kind of like gym equipment for sleep, and so that someone could literally go somewhere and take a nap and go back, and it's not clogging up a room that could be a workspace or that needs a linen change. And then we have to facilitate strategic consumption of caffeinated beverages. Again, I'll show you how to do some of this in our next few minutes. So so what should we be thinking about in terms of fatigue mitigation management? So we got to practice good sleep hygiene. So protect your sleep time and be consistent. So I actually do best with 7.5 hours. That seems to be my number. And so you really have to think about, are you, and no one is 100% efficient. So if you're getting into bed and falling asleep within a minute or two, or when your head hits the pillow, and then you're needing an alarm to get up in the morning, you're probably a little sleep deprived, and two, not spending enough time in the bed. So you need to extend that time a little bit. The best thing people can do for themselves is pick a regular bedtime and routine. Don't eat too close to bedtime. I actually, sidebar here. I remember actually being able to eat dinner in my bed and then put the plate on my night table and being able to fall asleep from how sleep deprived I was during my training. And then regular wake times are important as well. So be consistent. And the recommendation is not to use the snooze button. Some of the restorative stages of sleep that we really need is occurring in those early morning hours. And when you're hitting the snooze button, you're interrupting that. And when you doze back off to sleep, you may have lost the opportunity to be in that stage. And one thing I put here in red, getting up at the same time is more important than going to bed at the same time, because it sticks, it just gives you that regularity. And you don't want to keep shortchanging your sleep by going to bed later and later. But for someone who's trying to be consistent and maintain healthy sleep hygiene, it's a lot easier to go back if you've been sticking to the same morning routine. You saw this on a couple other slides, but I'll just call it out. You got to think of a cave. The sleeping environment is important. It should be cool, dark, and quiet. And if you know you're going to have to be awake up all night, either because you're working in the hospital or because someone is taking call from home and it tends to be busy with a lot of calls, you got to increase your sleep time before extended shifts. And that's not necessarily because you can bank your sleep. It's really because most of us are already somewhat chronically sleep deprived. And so getting a little bit more and making sure the tank is full is really important. And then if you are someone who's getting your right recommended of hours of sleep every night, then if you do have sleep deprivation, you want to try to sleep extend for a couple of days after the sleep deprivation period. You don't need to if you lose 8 hours of sleep, you don't need to make up hour for hour, but it's usually about for each night, you could for the subsequent nights after 1 hour of sleep deprivation, after one night of sleep deprivation, you can extend your sleep by 2 hours each night and feel pretty good, as if you've matched that 8 hour sleep loss with that 4 hours of extended sleep time over 2 days. And what about for people who are having trouble getting to sleep? So you want to get regular exercise. You don't want to get that exercise too close to falling asleep, because while exercise is great for reducing your sympathetic tone, it actually raises your body temperature. And we want our body temperatures to go down at night. That's part of what is happening during their circadian rhythm changes. And then there's a lot of relaxation techniques if you can't fall asleep. I won't spend too much time on these here. You can see I have some of these are free: Insight Timer, CBTI Coach. Headspace is actually free right now for healthcare professionals, but I think it ends at the end of 2020, and they haven't extended it yet. Progressive muscle relaxation. Reading is okay, but you have to remember light is not your friend. So you just want to be careful about those e-readers. Certainly texting, social media, even our TVs have such brilliant blues now that that wavelength of light is actually telling your brain to stay awake when you should be unwinding and going to sleep. So certainly not doing pen chart or my pen medicine messages close to bed. And just think about how you feel in a summer evening. If you take a walk after dinner, you might be a little bit harder to fall asleep, and that's because you've been exposed to light. And then this is just to point out that it's actually the wavelength, the exact wavelength of blue light that is actually what communicates to our circadian rhythms and tells us, oh, it's time to be awake. And so that's why we talk about avoiding electronics. The Apple phone, the iPhones have that night shift on it. And then there's one for PCs called Flux, and you can set the time that you want it to be, and it will pull the blue light out. I will disclose that there was a small study that looked at effect on circadian rhythms using that night shift, and it didn't have that much of an effect. But nonetheless, for people who are having trouble falling asleep, a little less light is what we recommend. If you Google blue light canceling glasses, you will see there's blue light canceling a lot of things, but this is, in fact, my son is in college, and this year part of the swag they sent when they told everyone to stay at home and be virtual was blue light canceling glasses with you know, the little school emblem on it. So now it's become school swag to wear blue light canceling glasses since everyone's in front of the computer so much. You can even get amber light bulbs if you like to read a book in your bed and you want a night table lamp. That's another way to get the blue light out. I mentioned about recovery sleep here, so I'm going to skip this. What I'll say about night shift, because I don't know how many people here that this is relevant to, but the idea is that it is okay to split the sleep. In fact, sometimes that works a little better. Again, because of the circadian drive for wakefulness that's very high in the middle of the day, it can be very hard to fall asleep. In fact, someone can be up all night and then just to walk to the bus and wait for the bus and have to get home in the light, they can get home and find that they have trouble falling asleep. So I always recommend, no matter what the weather is outside, people should wear dark sunglasses if they have to wait to the bus. They should make sure that they've left their apartment with all the shades down and dark so they get into that dark cave. And I even recommend getting blackout shades to keep the room really, really, really dark. And for people that might be transient or renting, I tell them they can go to Home Depot or Lowe's and buy paper blackout shades for, I used to say $7. I think they've gone up to 12 now, and you just stick them to the top of the window and let them hang down. I'm just showing a picture of what some of the, these are called nap pods. They have these in the Vancouver airport, and actually Stanford Hospital has them. And then there's the nap cabs. I don't know, this is at an airport in Germany. I don't know if anybody has seen them, but essentially this is, like I was mentioning, gym equipment for napping. You can clean this afterwards. You can plug your headphones in and play music, or in the Vancouver one, I think it just plays its own music. And this little capsule can kind of come down. So I think it would be a neat message to send if we had these types of places available for, we have people working in the hospital right now, as many of you may know from COVID, that are not used to working in the hospital. And when asking where they could go to sleep, some of the response back is like, well, people aren't really sleeping at night. And so I do think that we need to really rethink this. And the reason for that is that naps temporarily improve alertness. Even a 30-minute nap will improve performance. In fact, if people don't like that hangover sort of sleep inertia feeling, a nap less than 30 minutes will allow them to get a good 2 hours of performance after that and not have that hangover effect, as I mentioned. And actually the studies that were done showed if you drink coffee right before your 30-minute nap, you wake up that much better. And this is sort of the same concept as what happens on transatlantic airline flights, where one of the pilots takes, I think it's about 40 minutes. They basically have a cup of coffee, they take a 20 or 25-minute nap, and then they have 5 minutes to sort of get themselves together and get back on track. Certainly longer naps, like 2 hours, will allow for that sleep cycle that I described to occur. But again, there is not everyone has 2 hours to sleep, depending on when you're doing it. And also this idea about sleep inertia, people can say they feel worse after a 2-hour nap for that reason. So what about caffeine as a countermeasure? Really, strategic consumption is key. And the effects occur within 15 to 30 minutes and have a 3 to 7 half-life. The issue is if someone's drinking coffee every day when they really need it, it isn't working. So I often tell people they should detox from it so that when they drink it, it really has an effect. And the right dose is about 200 to 300 milligrams. And I often put this up just to show a brewed cup of coffee is really how you get there. All these things like Jolt and Red Bull, they're really small potatoes in terms of how much caffeine you're getting. And so if you're strategically doing it, you just want to have a nice brewed cup of coffee. And then I should also say that people often think that the darker roast is the way to go because it has that heavy flavor, but actually it's the breakfast blend, the milder blends, the milder roasts that have the most caffeine in them, because the dark roasting process takes the caffeine out while it keeps the flavor. I won't spend too much time on this in the interest of time because I want to give us a few minutes for questions, but essentially this study is old. It was done by Dr. Pack in the mid-90s using driving records from North Carolina. This just shows the time of occurrence of fall asleep crashes, and I just want to point out here how much can still occur at 6 or 7 o'clock in the morning. So when you think about if someone has been awake all night, they don't have that, they have a very high homeostatic drive for sleep, and the circadian drive for wakefulness has not completely kicked in yet. And so I do worry about people who work a 24-hour shift, or even when we were on the 16-hour shifts and people were leaving at 6 or 7 o'clock, this was a really vulnerable time. I'm going to skip that. I do have some slides on if people are having trouble falling asleep, and in part this came out of, and some of this I've already told you, this came out of the new term coronasomnia that was really prevalent, and maybe still is, but was really at another pandemic or epidemic, I should say, in the spring, where people were very charged up and having trouble sleeping. And so we provided this for our, Phil Gehrman actually helped me with this from the Sleep Center, who does a lot of cognitive behavioral therapy and for insomnia particularly. And we shared this initially with the house staff, and then it was shared more broadly with staff. So we can come to that if anyone has any questions, but I won't spend too much time on this because I've told you a lot of it. The one thing, yeah, I'll just leave that. So I do think the other thing that is really important is that many people will use alcohol and to help them fall asleep. It definitely makes you feel drowsy, and it might help you fall asleep faster, but it does affect the sleep architecture. And so people are actually less well rested, and they wake up more during the night when they use alcohol. So that's another message we try to get out. I think this may be relevant. So individuals who are working from home and take a call in the middle of the night, they may have trouble falling back asleep. And if they don't fall asleep in a few minutes, the best thing is to get out of bed and leave the room if possible. Stop thinking about sleep. You kind of want to break the cycle of frustration and worry. We can go back to some of those relaxing activities that I mentioned in terms of meditation and deep breathing and those apps, even in the middle of the night. And then once you feel sleepy again, get back into bed. You know, I tell people if your phone is your alarm clock, move that to the other side of the room, move your alarm clock to the other side of the room, and don't watch the clock. And then even if someone does have insomnia that lasts for a long period of time, either because they took some calls in a row and then after that they have a long stretch where they're not sleeping, 90% of the time it does resolve back on its own. I think I'm gonna stop here. Let me, oh, you know what? I'm not gonna give you guys the quiz just because I realize the time. But the other thing I wanted to point out about taking calls from home is that before you have a problem where you might be awake in the middle of the night, there's a few things that you can do. One is you can minimize the light exposure if possible, like try to keep the room as dimly as you need to be able to either write something down or jot notes or look on the computer, and maybe put your computer light on dim, as I mentioned. And then after you're finished with the call, write down any lingering thoughts that you're like, okay, tomorrow I want to check X, Y, or Z, or I didn't think of this in the differential. Presumably it can wait and you can talk in the morning. And so writing it down will help reduce lying in bed, dwelling on the call, and thinking about what you want to do, because you know you gave your sort of a data dump on the pad so that you can return to your thoughts and questions in the morning. And then if you do recognize that you're feeling wound up or alert after the call, this is where getting out of bed, moving into that dimly lit, quiet place and doing a non-stimulating activity maybe just enough so that you can get back to bed and that you don't have that sort of permanent, more long-lasting experience of insomnia. So I just want to comment on a lot of those things are things we as individuals can do, but I do think we need to think about what is the balance of extended shifts versus night shifts for people who are working in the hospital. Make sure that the shifts are rotating in the right way. I personally think we should be limiting the number of nights in a row. I do think we all certainly know people, there's certainly like night nurses, for example, who have been doing this for years and have been able to switch their clocks, so to speak, or they probably tend to be much more night owls than morning larks, and so they can adapt in this way. But most of us cannot do this, and I think that the thought that people might adapt in a 1 month of nights is really hard to do, because people on the weekends go right back to where they right back to the schedule they want to have. We have to have adequate sleep spaces. I don't think it's a good message to say we're not sleeping when we're here, because I think we can't all be sleeping at once, but we could all take a nap if we need it, and we need to make sure that we have availability of caffeine. So I have only left us 4 minutes, so I'm going to stop there and see if anyone has any discussions or questions that I can answer.
Folks, to ask questions, please unmute, or if you don't want to do that, post a question in chat and I'll pass it along. Well, Ilene, I have a question. You alluded to it, but maybe expand a little bit more. I have like other people on this call, I suspect I have a well-established nocturnal interrupted sleep pattern. Bimodal sleep pattern, wide awake for 60, 90 minutes, starting at 2 or 3 o'clock in the morning. Should I be doping up with large amounts of short-acting drugs? Or what is thought about where this pattern comes from?
Yeah, so it's hard to know exactly where it comes from, although I'll tell you that historically, there are some reports of something called first sleep and second sleep. So this idea that people would fall asleep at 10 or 11 o'clock and then be awake 1, 2, or 3 in the morning for an hour or so, and actually go around some of their usual activities and then go back to sleep. And then somewhere along the way, we became a society that condensed all its sleep into one period. So what I would say is, if it's disturbing to someone that they're having that wakefulness in the middle of the night and not able to fall back asleep, or certainly having performance issues during the day, we typically don't recommend medications for insomnia that is more chronic, or sleep disruption that's more chronic like that. And so if someone wants to try to get rid of it, we usually recommend sleep restriction, spending a little less time in the bed until you're sleeping the entire time. Again, that's where you pick that set. If the wake time is set, then we pick a different sleep time for a little while, and you sleep through the night. And then we add more time back. I'm simplifying this a lot. There's a whole field of behavioral sleep medicine now, and essentially we call this chronic behavioral therapy for insomnia, which works as good, or in many cases better, than medications. I think someone asked about melatonin. Yeah.
A question about melatonin, David McCarthy. Yes.
The answer is maybe. So melatonin is essentially it's a naturally occurring substance that we all have that actually starts to appear as the sun starts to go down. It is that rise in melatonin that interacts with the circadian system and starts to tell the brain to start to think about going to sleep. And it's in, very, very small amounts. So when you go to the health food store and pick up a 1 milligram or 3 milligram or even 5 milligram tablet, you're sort of super physiologic doses. And it can have an effect of making someone sleepy enough that they fall asleep. And also, as we age, it may be that the fluctuation in melatonin is dampened a little bit. So adding that at night to signal the system can work. What I will tell you is that we often try it first, or I tell someone they can try it if they want to. And then if it does, it's just that it doesn't always work reliably well. And so if it hasn't worked after 2 to 4 weeks or so, I tell people to stop it. It's not, doesn't have many downsides, but except maybe some nightmares in high doses, but it may or may not work.
One more question, somebody? Eileen, thank you very much for joining us today. It's absolutely wonderful, right on target, and I'm sure helpful to many other people in the group. So thank you again, and we'll wrap up this noon session. Well attended, I'm sure partly because you were on the schedule. Thank you, everybody.
Thanks. Okay, bye.